Kia ora koutou. Thanks, Sam. So I'm looking around the auditorium and I'm going to make a guess that everybody in this room is over 20. Maybe not some of the Mātai interns or Oliver, but most people I think would be over 20. And if so, that means that we are all in various states of cognitive decline. So sorry to break that to you. Processing speed has a steady decline from 20 years of age. And for some people, reasoning and spatial processing may deteriorate from your 30s. From 60, it's quite likely that we'll experience decline in memory. The good news is that this cognitive decline as we age is all completely normal. But for some people, the rate of that decline is faster and more severe. And if this cognitive decline is so pronounced that it impacts a person's ability to function normally, so for example, their memory is so impaired they can no longer do their job or go about their normal daily routine, then this is what signals then a dementia diagnosis. So dementia, or mate wareware, can be caused by a variety of different diseases, but Alzheimer's disease is the major cause of dementia. And with an aging population and the tsunami that we heard about yesterday, this is projected to increase by up to 150 million people with Alzheimer's disease by 2050. So to diagnose Alzheimer's disease is the cause of a dementia, we look for this trio. We look for a protein called amyloid in the brain. We look for another protein called tau, and together those two things can lead to neurodegeneration. And so for amyloid and tau, to check their presence in the brain either requires a PET scan, and that's an injection of a radioactive isotope, or we can take some fluid from around the spine. And these types of tests, though, they're not actually very accessible in New Zealand. So CSF samples still have to be sent to Australia for testing, and PET scanning for these particular proteins only can happen at a few sites in New Zealand. But for neurodegeneration, we could also use PET and CSF, but we can also use magnetic resonance imaging. And that is something that's more accessible here in New Zealand. So you should be able to see that in this MRI scan, the sign of neurodegeneration is that there's volume loss in the brain. So there are gaps up here around the temporal lobe. Normally the brain is nice and plump and you wouldn't have these gaps. And also you can see around the hippocampus, it looks shrunken, and the hippocampus is a key component in memory. So we can use MRI to look at neurodegeneration, but not these other two proteins. So 2 years ago, I'd be standing here saying to you, there are no treatments for Alzheimer's disease. And then we got this wave of new amyloid-depleting drugs coming through from clinical trials. I call them the MABs, mainly because there's so many different variants, but also their names are quite hard to say. And I've just listed a few of them here. So all of them have been shown to gobble up amyloid. They take amyloid out of the brain, and we know that that's a risk factor for Alzheimer's disease. But even though they take away amyloid, the reduction in cognitive decline is actually pretty marginal with these drugs. So the first drug, aducanumab, was actually really controversial because even though it took away amyloid, it didn't make any improvement in remembering, learning, reasoning, or functioning compared to a placebo. The last one that's on the list there has been shown to be a bit more successful in that it slowed down some clinical progression. And this is after it's injected every month for a year and a half. There was some improvement in cognition, but they don't halt or prevent dementia, these drugs. They just slow dementia or the progression of dementia down slightly. The other thing to note, though, about them as well is that they actually have some pretty nasty side effects. So they can include headache, confusion, delirium, disorientation, and more worryingly, brain swelling and even brain bleeds. So here's just a few examples of that. So fluid on the brain in these two examples here, and then bleeding, so these microhemorrhages or microbleeds on these other types of scans. And these actual side of that last drug that I mentioned to you that was more effective in terms of cognition, a quarter of the people on the drug had this fluid on the brain with taking the drug. So what we know so far is that treating amyloid in Alzheimer's disease patients is not really that effective yet. But what we're looking at is what if we could actually catch people early on in this dementia trajectory before the loss of function. And so for these people that have something called mild cognitive impairment, they have some cognitive decline that's more than normal aging, but before they've got to a point of dementia, before loss of function. And it might be that they've developed strategies like making lists or other ways to cope that means that they can still go ahead and function normally. The rate of cognitive decline is quite variable. Some people actually remain stable and don't progress to dementia at all if they have MCI. But why are there these different trajectories? We don't really know why some people are stable and some people progress to dementia. And what we're wondering then is if there are other changes in the brain that increase the risk of progressing to Alzheimer's disease that are not amyloid related that we could treat. And I think actually this is where MRI can play a really large and prominent role, because we know MRI is really good at imaging both brain structure, that's what it looks like, and also the function, so how it's acting in the moment. And so the aims of the Dementia Prevention Research Clinics is to identify a biomarker signature. So biomarkers are a measurement that we take about the person, and we think there's a combination or a signature of these markers that will predict progression from mild cognitive impairment to dementia. Importantly, this is in a New Zealand cohort, and it's the first New Zealand study of its kind. We don't know what those trajectories look like in a New Zealand population, and there might be multiple different biomarker signatures that differ by culture, ethnicity, and environment. And we want to ensure that the sample represents the ethnic diversity of New Zealand, so especially Maori, but also Pacifica cultures and Asian cultures. How do they impact that biomarker signature? Hopefully you can see that we need to be collecting data over time in the same people. So in this example, this person here had mild cognitive impairment on their first baseline scan. 2 years later, they still had mild cognitive impairment, but at year 4, they progressed to dementia. And what we're really trying to find out with this study is there something then about their baseline scan or about their brain earlier on that can help predict that they would progress to dementia? So far we've scanned, we've enrolled, I'm just mainly interested in the scanning, but we've enrolled nearly 400 people. We're recruiting all the time, and people have follow-up appointments every 2 years. And actually just a few months ago, we had our first F8 participant. That means they've been in the study with us now for 8 years, and they've had 5 MRI scans, and we actually had a little party and a cake after the scan just to celebrate what feels like quite a big milestone for this study. We collect data from different platforms. So people come in, they have extensive neuropsychological testing with a clinical neuropsychologist. They give a full medical history and lifestyle history to a doctor. They provide a blood sample, and then they have some imaging. So a subset of the people will have amyloid PET, and everybody that comes through has an MRI scan. So we collect a range of different MRI scans. Each one of those have been picked to study a different aspect of the brain. And so one aspect that I'm particularly interested in is cerebrovascular health. And what that means is it's anything that's related to the health of the blood vessels themselves, or the blood that flows within it. And the work that I do is how do we measure cerebrovascular health with MRI? So there are multiple projects that we're doing that are all related to Cerebrovascular Health, and I've just put them up here along with the MRI method that we are using to study them, just in case if that sparks any interest for you, the mechanisms or the scan method, then please do get in touch. But just for the sake of time, I'm just talking about this last project, and that's related to what we call macrovascular or large blood vessel flow. So we think that changes to large blood vessel flow can increase the risk of dementia by two different mechanisms. So the first one might be that we've actually just got reduced blood flow in those large vessels. That in turn will be reduced blood flow to the smaller vessels and the capillaries that feed the tissue, and with that reduced blood flow would lead to neurodegeneration. The other aspect we're looking at is poorer vessel compliance. So a nice compliant blood vessel will stretch and contract as the heart beats, but a vessel that's stiffer, it can't do that stretching and contraction, and it can't regulate blood flow within the vessel as well. And there's some downstream consequences of that, in that there might be impaired nutrient delivery, and also that a stiffer vessel isn't as good at actually moving things out of the brain, and maybe, for example, removing amyloid out of the brain.